All right, well, I thought I'd start off with a little bit of a primer on radiation therapy. It can be a little bit of a black box to folks, usually conjures up thoughts of Marvel superheroes and whatnot. But many patients with cancer will receive radiotherapy at some point in their treatment course. It's a fundamental part of curing a number of different cancers, prostate cancer included. And often, as Sam mentioned earlier, can be used in conjunction with surgery, additionally with systemic therapies. And I thought we love like physics in radiation oncology, so I just thought I'd throw a diagram here. Probably takes you back to some of your high school physics. But the idea behind radiation is that oftentimes we're using what are called photons, which transmit radiation. And the idea is that these photons or this radiation creates essentially DNA damage. And there are different ways to do this, whether it's by a direct action from the radiation itself or through an indirect radiation action that's mediated by other particles in between. And the idea is that this sort of more selectively impacts cancer cells than it does normal cells. And that gives us a little bit of a therapeutic advantage, which we've historically used to treat a number of different types of cancers. And so this ability for normal tissues to repair DNA damage between treatments, in contrast to cancer cells, is a fundamental part of how we deliver radiation, which has sort of been advanced over the decades that it's been used to take advantage of better technologies that allow us better spatial resolution and how we focus radiation, which I'll talk about a little bit today too. Radiation plays a role in a number of sort of different stages in the prostate cancer domain. Certainly, we're here to focus on localized prostate cancer, but I'll actually talk a little bit later today about the oligometastatic situation where prostate cancer has spread to limited areas outside of the prostate, but certainly other areas where we do apply radiation therapy. And it's frequently, I guess it's become a bit of a cliche that radiation is a little bit of an alphabet soup. But there are a number of different types of radiation, and in 10 minutes, I don't have time to cover everything on this list. But a number of sort of different domains that are covered here, radionuclides. I think there's, of course, an increasing interest in lutetium, PSMA, which we won't get a lot of time to spend on today. But most of the radiation that we'll discuss sort of fits into the external beam section here. So that's sort of split into proton therapy and photon therapy and a number of different subtypes. And then brachytherapy, which involves internal radiation sources that can be delivered in two flavors, both low dose rate and high dose rate brachytherapy. And this sub-quadrant, I guess not quite a quadrant, but this subsection of the graph is largely the radiation options that we discuss and present when someone has localized prostate cancer. And since one of our brachytherapy experts is not represented on our panel today, I thought I'd just at least throw out a pitch for those guys. But brachytherapy is essentially internal radiation that can be done with permanent or temporary seeds. And this is just an example of an HDR plan. This is a little bit more of a procedural, but a sort of a more limited duration type of treatment that we use with radiation therapy. But I'll talk a little bit more about the external beam radiation, since that's kind of the most common radiation that folks encounter when they undergo treatment for localized prostate cancer. Again, in a bit of an alphabet soup, you'll hear a lot as you learn about radiation with regards to conventional fractionation. The standard technology for delivering conventional fractionation is IMRT or VMAT. It's actually used for all three areas that I'm discussing, but you'll frequently hear IMRT in reference specifically to conventional fractionation or moderate hypofractionation. And so I often tell folks that, years ago, we used to do most of our radiation courses with a couple of months plus of radiation therapy. And then there were a number of trials that demonstrated that we were able to deliver a higher dose of radiation per treatment over fewer treatments. And so now very commonly you'll see what's called moderate hypofractionation for external beam radiation, which typically is 4 to 5 weeks of daily radiation Monday through Friday. And then naturally, once the treatment courses were shortened down to a month or so, there was sort of the question, well, a month's still a long time, guys. Can you guys do this even faster? And in that era, we started adopting a newer technology called stereotactic body radiation therapy, or SBRT. It's frequently also termed ultra hypofractionation. But those treatments go for 5 treatments over the course of about a week and a half here. So I thought I'd show you guys a couple of pictures to kind of demonstrate the differences in some of these technologies. One of my analogies was, I don't use as frequently as I did years ago, is the Death Star. But the idea is that radiation, when it's delivered externally, comes from all sorts of different directions, and it's focused over one specific region. So, before this was delivered with a technology called 3D conformal, and I often joke that as physicians, we're not terribly creative. So these radiation beams would basically come from 4 directions: the front, the back, and then the sides. And as you can see, there was a lot of scatter radiation back in that era. Eventually, intensity modulated radiation therapy and then its subtype VMAT, which is what we use here, were developed where radiation could be backwards planned, where the radiation oncologist can define where the radiation needs to go and where we want to avoid radiation. And then from there, use algorithms to work backwards to generate a radiation plan where the radiation is basically focused in a specific area, and then low dose radiation is sort of more spread around. And that enables us to reduce the amount of side effects and the impact from the radiation on other organs. And as a number of folks have mentioned already today, treatment for prostate cancer is a very highly personalized situation. But I thought I'd at least give some broad strokes as a starting point for what is often discussed for different risk strata of prostate cancer. So on the radiation side, technologies such as IMRT and SBRT are frequently options that are presented across all of the disease spectra. And then brachytherapy on its own is sometimes a consideration in the sort of more favorable situations. And then as we increase in risk, we start talking about combining external beam radiation with IMRT with brachytherapy. And then there's some considerations around hormone therapy. And these are just broad strokes. And certainly there are a number of nuances for making these decisions. We start off with risk stratification, sit down, discuss options, usually sort of separate options with regards to radiation and hormone therapy. And then we try to work in the preferences to try to come up with something that seems like an appropriate strategy on a personalized basis. Certainly discuss it with our surgical colleagues. Sometimes he did, Sam. And then we proceed to treatments. And then we continue to see you and follow up to both surveil the prostate cancer, but also to discuss side effects that may come up in the future. So I thought I'd present kind of in broad strokes what kind of the radiation experience is like. And this is sort of the typical care path. And we'll go through each of these steps as we go. So this diagram will be around throughout the rest of the slides. So the first step is what we call a CT simulation. And I usually colloquially refer to that as a planning scan because it's a more accurate name in today's era of radiation. There's the first part, which is gold seed markers that are done by our urology colleagues. These allow us to triangulate the prostate as we go through treatment. And then there's a CT scan, which may or may not be accompanied by an MRI. And these pieces of imaging allow us essentially to create a computer model of your body to design the radiation. We also oftentimes use some sort of immobilization to make sure the radiation is reproducible on a daily basis. And then probably one of the harder maneuvers that patients have to go through during radiation is bladder filling. And we often recommend that we fill the bladder, which allows us to get a little bit more anatomic and geometric separation because the full bladder gets farther away from the prostate and also pushes other organs away from the prostate to spare them from radiation. After that CT planning or the planning scan, patient goes home and then we do what's called dosimetry or radiation planning. We take all of the imaging, which may include a PSMA PET, may include an MRI, plus the radiation planning CT, and essentially trace out all of where the radiation needs to go, in the localized setting, for instance, the prostate, but also all of the normal organs, which is where a lot of the sort of operator dependency of radiation comes into play. There are often patient-specific considerations for what areas we want to avoid radiation and certain organs that we want to protect. And then once we create that computer model, we work on designing the radiation plan with our medical physics team, who are all PhDs in medical physics, and other folks on our team who go to school specifically to design these radiation plans on the computer. And then in the bottom right-hand corner is just another example of how we design the radiation to create focus plans. All of this goes through a quality assurance program. I like to say that it's basically something similar to a dummy that we deliver the radiation on to make sure that what we program in the computer actually happens in real life before we start the radiation treatment. It's not quite a dummy, it's actually a glorified box, but same idea. And then the radiation treatment starts. I usually tell folks the radiation beam for most treatments is on for about 5 minutes or so. The entire process on a day-to-day basis, whether you're doing SBRT or a longer course of radiation, is usually probably about 15 to 30 minutes on a given day, depending on how kind of quickly everything is going. But the radiation itself is on for about 5 minutes. And the process is basically like getting a glorified X-ray each day. You don't see or hear or taste the radiation. You won't glow in the dark, no superpowers or anything like that. And as you go through the process of radiation, one of the elements that we use specifically in prostate cancer is tracking with the gold seed markers. And so on a day-to-day basis, we review the image to make sure that everything is in alignment. We can also check where the rectum is, where the bladder is, to make sure those things are being protected while we're doing radiation. So this imaging during treatment is really important. And as the radiation machine is going around in a circle, what the beam is doing is changing configuration, basically to shape specifically to the target that it's aiming at. And from every direction, this beam is constantly changing to mold radiation to the right shape. And as we go through treatment, we see each other every week. And there are a number of side effects that we discuss in the short term, which are side effects that come up during radiation and in the period shortly after. Most of these side effects will show up kind of midway through the treatment and then peak a little bit after the treatment before they start to improve. And then there are long-term side effects, which come up months to years after radiation. Some of these can take several years. So for instance, rectal bleeding, which I have listed in long-term side effects, plateaus at about 7 years out. So many times, I think Dr. Washington was discussing sort of post-surgical side effects, which sort of improve after surgery. Radiation is a little bit different in its timing, where things can kind of show up over time. So it's very important to have consistent follow-up over time, both during and even years after the radiation. As you can tell, these side effects are all sort of related to organs that are close to the prostate. So the bladder, the bowel, the rectum are all areas that can be affected. And I think with that, I'll wind down. Thank you.